So I'm going to present my case. My patient, 50-year-old male, he's resident of Patna, Bihar, postgraduate by education and LIC manager by occupation. History is given by the patient himself. He is a known case of hypothyroidism for past 10 years and taking thyroxine 50 microgram OD. And he is having history of cough with hemoptysis for past 20 days. He along with shortness of breath for past 15 days and malaise for past 15 days. So he presented with history of cough of 20 days duration, that is insidious in onset and productive in nature, and having a red color sputum that is mixed with fresh blood, and it is about 2 to 3 teaspoons.
Anvesh, can I just stop you? I'm going to ask everyone to switch on your videos because I don't like talking to people who I can't see. Okay, so everyone switch on your videos. If you don't switch on your videos, I will kick you out. Yes, go ahead, Anvesh.
Yes, sir. So he is having a cough of 20 days duration that is insidious in onset and productive in nature. It is associated with red color sputum that is mixed with fresh blood, and 2 to 3 teaspoonful in quantity, and having about 8 to 10 times a day. It is not any foul smelling is there, and it is aggravated by dust and smoke. It is not associated with any fever, chills, chest pain, and having no diarrheal variation. It is persisted throughout the day as well as night, and it is having no history of weight loss, evening rise of temperature, or no striders or wheeze. He is also having shortness of breath for past 15 days.
You said there was no fever, right?
Yes, sir.
Okay. Because you're saying there is no evening rise of temperature. For that, there should be some temperature, right? So don't say something which is not there. Okay.
He is also having shortness of breath for past 15 days that is gradually progressive, and now it's limiting his routine physical activity, but he's not requiring any oxygen support at rest. This shortness of breath is not having any specific exacerbating or relieving factors, and there is no it is also not associated with any chest pain, palpitation, sweating, and no postural preference for shortness of breath, and no having history of no history of paroxysmal nocturnal dyspnea or orthopnea was there.
All right.
So he was also having a history of malaise for past 15 days. It is also associated with some loss of appetite for past 15 days. Right. He visited in Patna to nearby physician and prescribed some antibiotics and as well as cough syrups, and nebulization were advised. He took the treatment for about 5 days and not improved, and having the persistent cough and shortness of breath was there. So for that, some blood investigations and X-ray was done, and the antibiotics were changed after the 5 days. He was also given the prescribed some oral steroids as well as anti-allergic medications and nebulization. The name he didn't remember. So that time his blood reports, routine blood investigation was also repeated. That was showing the normal parameters.
How do you know he received antibiotics and oral steroids?
The antibiotics, he itself told that the name of antibiotic that previously he was given some amoxicillin was the antibiotic, and about the oral steroid he also suggested the name that some small tablet having the Visolon was given. Okay. The dosing he didn't remember. The Visolon tablet he prescribed. Okay. So at that time blood investigations was done and was told that this is of normal values, and after this antibiotics he was again not improved, so again visited to the same doctor, and
doctor band karo. Tell me about the progress of the patient. Don't tell he went to this doctor, he received this, and then this investigation was done. This is history, right? This is not a recitation of his doctor visits.
So after 7 days he visited, and that time the blood reports were done, and that
What
showed.
happened to his symptoms, my friend? I don't care whether he visited a doctor or not. Were his symptoms getting better, not getting
No,
better?
symptoms were not getting better. He was
Well,
persistent having cough.
say that, right? So say that despite treatment, his symptoms did not improve. Okay.
So despite taking all this treatment, he was not improved, and his cough was persisted, as well as the shortness of breath that was gradually progressive.
So this is for now from today. How long back did this start?
So this is total 20 days of duration. When I took the history, this is of 20 days duration.
And over these 20 days, have his symptoms worsened over time? Have they remained stable? Have they improved? What has happened?
No, the symptoms gradually worsened over the time.
Right.
Initially, he was having, he was not having the, initially he presented with, he was having
symptoms worsened over time. Don't repeat yourself. Okay. All right. So then after that, so the only symptoms he has are cough and hemoptysis and shortness of breath and malaise. That's all.
Yes, sir.
Okay. And these are the symptoms he presented to you with.
Yes, sir.
No other symptoms.
No, sir.
Okay. All right. Continue with your history.
So he was previously told that his blood investigation were normal.
Don't get told, you know. What happened to him? What?
So once he was advised that again he not improved, so he revisited to the physician, and then he was investigated again. So for that time, the blood parameters was showing the increase in the creatinine values. He was for that he was not having any history of NSAID use. He was not having any history of oliguria, edema, flank pain, hematuria, joint pain, or rash, or any indigenous medicines. He was during these 20 days course, his blood pressure would remain within the normal limit, and he was not having any visual blurring, and any history of headache was not there.
Okay.
Yes, sir.
Anything else?
No, sir.
Was his appetite been normal all through?
No, he was having malaise for past 15 days. So with
malaise is not the same as the appetite, right?
No,
What is the meaning of malaise?
Malaise is generalized appearance of generalized feeling of illness, as well as some not feeling well.
Not feeling well, body aches, those kinds of things, right?
Appetite was reduced in 15 days. Appetite was gradually decreased.
What happened to his body weight?
The body weight was same. He was having there was no history of given that any weight loss was there.
There was no change in body weight. Okay. All right. What are the other symptoms? He's a 50-year-old male who has some respiratory symptoms, and initial investigations show looking normal, and later on he's told to have some decline in GFR. What other questions did you ask? You asked urinary symptoms which are not there.
So I will ask for any specific the drug, that if he remembered any specific drug that were given during this period, and other than that, any history of hematuria during the.
Don't repeat yourself again. Nothing else?
No, sir.
All right, finish your history. We'll come back to it. Have you finished your history? Is there anything else?
No, sir. I completed.
Okay. So can you summarize your history in 30 seconds and then give me your differential diagnosis at this time?
So he's a 50-year-old male, known case of hypothyroidism with now presented with complaint of cough, hemoptysis, shortness of breath for past 20 days.
Okay.
And with declining in GFR, rapidly progressive, rapidly worsening kidney functions in 20 days period.
So what is a differential diagnosis?
So from history, so should I include the past history?
If there is a part, you haven't told me anything.
No,
You
this
said
is
your
the
history
present.
is finished.
No, this is the present history, sir.
अरे बाबा past history भी बताओ ना.
Yes.
History खत्म करोगे तब होगा ना.
So in the past history, he is having history of pulmonary tuberculosis 15 years back, for which he was treated for he treated for 6 months, completed the course from Dot Center, and he had also having the history of hemoptysis in 2017 as well as in 2020. Both times he was treated with some antibiotics and supported treatment on OPD basis for about 2 to 3 weeks and improved. And after that, there was no same illness. He was not having. He was having no history of diabetes, hypertension, asthma, or any drug allergy. In the personal and social history, he is having no history of addiction to the tobacco chewing or non-alcoholic and non-smoker. He is vegetarian by diet and having bowel bladders are normal. And the sleep and appetite were reduced for past 15 days. In the family history, he is having both parents are non-diabetic and having no other comorbidities, and the 3 siblings and having no significant medical history. Yes, sir, that's all.
Okay. So now tell me your differential diagnosis.
So from history points, it's looking rapidly progressive renal dysfunction.
That's it.
Yes, sir.
So if you are, when do you appear in your exam?
Sir, next year.
So you can add 1 more year. If I were your supervisor, I'll ask you not to appear in this exam. Is this the way? Has anyone else got anything better to offer in terms of differential diagnosis based on the history I've presented? No one? What is rapidly progressive renal dysfunction? ये syndrome कहीं लिखा हुआ है क्या किसी किताब में? Because this is the term you use. Rapidly progressive renal dysfunction. Is this syndrome, is this phrase written in any nephrology textbook? Okay, what is rapidly progressive renal failure? Okay, let me just prompt you.
So it is of the renal dysfunction that is of short duration from weeks to from days to weeks.
So
and
renal
having
dysfunction. Okay.
Declining in GFR.
Okay, decline in GFR. Now you have changed.
less than 50%. That more than 50% decline in the GFR.
So never use a term like renal dysfunction. Okay. If someone comes to you with proteinuria, is it renal dysfunction or no? Yes or no? What are the functions of the kidney?
Yes, sir, it's a renal dysfunction.
So that's what I mean, right? I mean, you need to be precise in what you're talking about. There is a definition for everything. There is a definition for rapidly progressive renal failure, which is related to eGFR. It is not related to any other function of the kidney. Kidney has a filtration function, kidney has a synthetic function, kidney has, endocrine function. There are many functions of the kidney, and anything that is abnormal is renal dysfunction. But we are not talking about that here, right? We are talking only about the eGFR side of kidney function here. So, which is defined as rapidly progressive renal failure. So you said a 50% or greater decline in eGFR. Anything more than that?
So in the duration of more than 2 weeks to 3 months.
2 weeks to 3 months. इसमें तो 20 days ही हुए अभी, right?
Yes, sir.
And what about 10 days? if someone has a rapid decline in EGFR over a 10-day period, what do you call it?
More than 1 week basically is included in the rapidly progressive glomerulonephritis.
Yeah, so anything weeks to months, that's all we say for rapidly progressive renal failure, right? What is the difference between syndromically, the difference between acute kidney injury and rapidly progressive renal failure? Both are related to decline in EGFR. So how do you syndromically differentiate the two?
The acute kidney injury having the duration of 1 week, and while the rapidly progressive kidney dysfunction having the more than 7 days.
1 week acute kidney injury as class में नहीं थी, इसलिए उसका definition नहीं पढ़ के आया. Anyone else has any difference of opinion about the definition of acute kidney injury in terms of the time frame? No? Acute kidney injury किसी को नहीं आती? I'm going to pick on people now. Saurabh Shukla, what is the acute kidney injury definition? Acute kidney injury is 48 hours, right? So the decline in EGFR, there is nothing like decline in EGFR for acute kidney injury definition. It is serum creatinine based definition, right? Rise to 1.5 times or by greater than 0.3 milligram per deciliter over a 48-hour period, or there is a serum creatinine criteria and there is a urine output criteria. Those are the things that you should know from your heart, right? That you should know by heart the definition of acute kidney injury, the definition of RPRF. RPRF is days to weeks. Okay. Right. So this is syndromically, this is RPRF, and this is where you are going to stop in terms of your differential diagnosis.
No, sir. In the differential diagnosis, the possible diagnosis could be as the vasculitis could be the first possible diagnosis, or other differentials could be the anti-GBM or SLE, or other possibilities of IgA vasculitis could be there. And while in other parameters, it can be precentric IgA nephropathy, as well as it could be AIN.
क्या बोल रहे हो यार, जो भी मन में आता बोलते चले जा रहे हो. I mean, this is a 50-year-old male who was presented with this illness. You yourself said he has a history of pulmonary tuberculosis, has had repeated episodes of hemoptysis in the past. That is, you didn't mention that at all in your diagnosis, differential diagnosis. That is not part of his history. Is that relevant to his presentation?
Yes, that is relevant to presentation.
How is that relevant?
If this is a case of vasculitis, then it could be a repeated episodes from the same illness or previous hemoptysis could be the recurrence of the disease.
But you said the previous illness was pulmonary tuberculosis. He was treated from it, right?
Previous pulmonary tuberculosis was treated 15 years back, and then again in the 2017, that is 4 years back, and 2020, he had 2 episodes of hemoptysis for about that was treated with oral antibiotics and improved in 2 to 3 weeks only.
Right. So can that happen to a person with tuberculosis in the past or no?
It can happen to the person with tuberculosis.
Right. And how likely is it that he had vasculitis at that time, did not receive any specific treatment and improved on his own?
Possibility of the bleeding from the tuberculosis itself is on the higher side, because it subsided within a few days without any treatment. So the vasculitis could not have been improved with so easily.
But you are saying it was vasculitis. That is what you are saying, right? So let's say a patient with past history of tuberculosis presents with rapidly progressive renal failure. What are the specific conditions that come to your mind?
So any
forget about this specific patient. Anyone with a past history of TB, active TB, now presents with rapidly progressive renal failure.
the infections related to the glomerulonephritis.
past history of TB. Yeah? This is not active TB. Amyloidosis सुना आपने?
Yes, sir.
Can it present with RPRF?
Yes, can present, sir.
It can present, but what else does it have normally? Do you think it is likely in this patient? Very likely or not very likely?
As he's having history of tuberculosis in the past, so could be the possible factor. Could be possible here.
So what else, if it was present, would make your suspicion strong? Anyone else? If you don't want to speak, you can write your answer in the chat box if you know the answer. Yes, Sapna, you have unmuted yourself. You want to say something? No? What is the other common presentation of amyloid? Yeah, so someone has written nephrotic syndrome, proteinuria, edema. Exactly. So that's the right answer. That such patients would normally be expected to have a coexisting nephrotic syndrome also, right? So they would have history of edema typically, which you said is not there in this patient. So amyloid is less likely from that point of view, but the presence of past history of tuberculosis, I would keep that in the list of differential diagnosis. Okay. What other conditions? You said vasculitis. Why did you make vasculitis as your first diagnosis?
Because he's a 50-year-old male. Previous 2 episodes of hemoptysis was there, and
So again, you just said that the previous 2 episodes of hemoptysis are unlikely to be due to vasculitis.
it could be because of we cannot rule out that.
But we cannot rule out anything in this world, right? But we are not looking to make the rarest diagnosis here, that someone presenting with hemoptysis improving on its own or with antibiotics to make a diagnosis of vasculitis in that person. That is not going to fly. Okay.
So he's a middle-aged person.
Yeah.
The 50-year-old male having no previous other comorbidities other than the hypothyroidism.
What else happens? What is the typical presentation of vasculitis leading to rapidly progressive renal failure?
It presents with general symptoms of malaise could be there. It
Yeah.
lead to
Which
the
this patient had.
yes,
this
sir.
patient had malaise, right? But you
Yes.
didn't use that as a a corroborating criterion in your argument. So that's one. What else?
Other than in the negative symptoms, he's not having any.
Positive. बताइए और क्या positive symptoms होते हैं to a patient who has vasculitis and presents with RPRF?
The pulmonary symptoms in 10 to 30% of the patients.
RPRF. Kidney symptoms. What other kidney symptoms should be there typically in such patients?
So should be there should be any hematuria could be
Yes.
there, but this
There
patient was
should be
not having any
hematuria, there should be oliguria, right? And again, there should be some degree of edema also because of low GFR, which this patient did not have, right? So that doesn't support your diagnosis of vasculitis leading to RPRF. You can say that the age, presence of some systemic symptoms like malaise, and maybe even if the hemoptysis was due to a different cause in the past, this time it could be due to vasculitis. So it could be a minor, and if the hemoptysis is due to vasculitis, what kind of vasculitis do you think would cause hemoptysis?
So it could be the.
You started saying everything. You started saying SLE, IgA vasculitis. Do they present with hemoptysis?
No, sir.
So that's why I'm saying, you should weigh your words as to what you say. All right. So what kind of vasculitis?
It's a medium vessel to small vessel vasculitis can lead to the hemoptysis.
Medium vessel to what? Give me a couple of examples of medium vessel vasculitis.
It's a Kawasaki disease and the polyarteritis nodosa are the medium vessel vasculitis that can
So,
lead to the hemoptysis.
polyarteritis nodosa leads to hemoptysis. Anyone? Yes or no? ये भी नहीं पता, किसी को भी नहीं पता। आप लोग यार क्यों आते हो क्लास में अगर आप लोगों को?
No.
So a couple of people are saying no. So they don't agree with you, Amnesh.
So mostly the small vessel vasculitis present with pulmonary capillaritis, involvement of the pulmonary capillaries. This can lead to the hemoptysis.
Yes, so it is the small vessel vasculitis that presents with hemoptysis, right? The only medium vessel vasculitis involving the lungs is Church-Strauss disease, and Church-Strauss also doesn't typically present with hemoptysis. Okay, so small vessel vasculitis. Give me a couple of examples of small vessel vasculitis.
So in the small vessel vasculitis, it could be the autoimmune as well as immune complex vasculitis. In the small vessel vasculitis, there could be the possibility of the types of the GPA, the granulomatous polyangiitis, as well as the microscopic polyangiitis, or it could be eosinophilic granulomatous polyangiitis.
Okay, you have GPA. What is the full form of GPA?
Granulomatous polyangiitis.
Okay.
MPA, that is microscopic polyangiitis, as well as
polyangiitis and granulomatous polyangiitis. So
as well as GPA.
Between these two, which one is more likely or less likely in this patient?
As this patient is having no involvement of the upper respiratory tract, he is having no history of any sinonasal tenderness was there, no features.
You have only presented history.
So no history of epistaxis was there.
Okay, so if there is no history of epistaxis, what does that mean?
It more favor to the MPA. It rule out the
if there is history of epistaxis, it might support GPA, but if it is not there, it doesn't rule out GPA. Right, so both can be present. Let's say, okay, we have already spent half an hour. What are the other conditions quickly that present with RPI? One is, you said, vasculitis.
anti-GBM,
SLE and IgA nephropathy are not likely. Okay, so don't even mention those. Anti-GBM disease. Do you think this is anti-GBM disease?
It could be anti-GBM, likely possibility.
Yeah. So, it is possible, but anti-GBM disease usually does not have systemic symptoms. So, if this patient truly had malaise, then that reduces the likelihood of this being anti-GBM. Anti-GBM is a non-inflammatory condition. Okay. So, when you are thinking of RPRF, you should think whether it is an inflammatory condition or a non-inflammatory condition. All right. So, there are a number of non-inflammatory causes of RPRF. Which include anti-GBM disease. It could be myeloma kidney. These type of conditions can cause RPRF, which is non-inflammatory. Right, myeloma kidney is something which you should always consider in a person with RPRF, especially a middle-aged to elderly person. If he was 70 years, myeloma will be even stronger. Right, hemoptysis is not explained by myeloma, but just as a condition in the list of differential diagnosis of RPRF, you should always keep myeloma in the list. Other causes, you said AIN. You think AIN is possible?
AIN could be possible.
Which one is more likely? AIN is more likely, or glomerular disease is more likely? Vasculitis is more likely?
He was having no history of hematuria. If I rule out the from history points, it's AIN is quite possible.
AIN is quite possible, right? I agree with you, because you yourself said that when he went to the doctor, his first evaluation showed normal kidney function, right? At least from what I heard you describe. And then he received antibiotics and so on and so forth, and then later on his kidney function deteriorated. He doesn't have any urinary symptoms. He doesn't have any edema. So it looks like it is a non-glomerular, at least from the history. So AIN is a good possibility. Okay? So that's something which you keep in mind. And again, I go back to the point of whenever you have this type of presentation, you should always think in your own head, what are the different components of the renal parenchyma or renal system that could be involved here. So you should always start with vasculature, large vessel, small vessel, glomerulus, then tubular compartment, then interstitial compartment, and then collecting systems. Any of those can lead to this type of. Can it be a large vessel disease? Unlikely, right? Large vessel disease will usually present with hypertension, will present with flank pain, because that is what happens in polyarteritis. Small vessel disease like hemolytic uremic syndrome. Do you think it could be hemolytic uremic syndrome?
But as in the history itself, for hemolytic uremic syndrome, there is no history of abdominal pain. No.
I'm asking you a question. Can it be or can it not be? First.
Unlikely.
Unlikely. Okay, for a number of reasons. Then you said vasculitis. We discussed vasculitis is possible. Then glomerulonephritis like RPGN, it is possible. All right. If it is glomerulonephritis, what other type of glomerulonephritis can it be? With this history.
The crescentic IgA nephropathy could be possible.
Crescentic IgA nephropathy is possible, but typically it is preceded by a prior history of IgA nephropathy. So they would have hematuria, right? So first presentation as severe crescentic GN with hemoptysis is not a feature of IgA, crescentic IgA. Okay, so that's something which makes it less likely. So in terms of glomerular diseases, there are no other conditions that come to mind, right, as the likely conditions. Then interstitium, acute interstitial nephritis is likely. Can it be acute tubular necrosis? Unlikely, right, because the way it has presented, but not impossible. Can it be something in the expiratory component? Can it be a disease, intratubular disease? That's also unlikely because that will lead to typically oliguria, right? If it was due to precipitation of some crystals in the tubules, etc. Right? So that's important. Okay, so these are the differentials. And then you must always remember that this patient has a past history of tuberculosis. This patient has a background of hypothyroidism and so on. Okay, this patient didn't have hypertension also from at least from history. I don't know what findings will be described in physical examination. So why don't we go to the physical examination?
So in the physical examination, he's conscious, oriented to the time, place, person, and in the lying comfortably in the bed, and the weight is 75 kg, moderate build, height is 5 feet 6 inches, and BMI of 27, and with average nutrition, and afebrile to touch. The pulse is 94 per minute, regular, normovolemic, no radiorenal or radiofemoral delay was there. All peripheral pulses were palpable. The vessel wall is not thickened. In the blood pressure in the right, in the supine position in the right arm, it is 126 by 70. In the left arm, 120 by 74. In the both lower limb, it is 146 by 90. Respiratory rate of 20 per minute with abdominal thoracic with no accessory muscles of respiration were in use. The pallor were present and the icterus, clubbing, cyanosis were absent. No palpable lymph node was there. No edema and JBP was not raised. In the systemic examination, the respiratory system examined in the sitting position, and on inspection, he is having no gross deformity, no visible scar or swelling. Bilateral chest movement was symmetrical, and no dilated veins or visible pulsation were there, and accessory muscles were not in. In the palpation, there is no tenderness was there. Trachea was in the midline, and the chest expansion was equally both sides. It is about 5 centimeter. On the percussion, it is intercostal. In the intercostal spaces, impaired not. And the liver dullness was percussed in the 7th intercostal space in the mid-clavicular line. On auscultation, the bilateral bronchial breath sounds were heard. In the cardiovascular system examination?
No, nothing in the respiratory system examination. We're describing a normal respiratory.
No, sir. There is impaired note on percussion as well as bilateral bronchial breath sounds. These were two abnormal
ये तो
findings.
आपने बोला
Bronchial breath sound.
where are they?
Pardon?
Which part of the lungs? You said
In-
bilateral. All over the both lungs?
In the middle and the basal part of the lungs and the both lung fields.
Middle and basal, ये क्या होता है यार? ये तो मुझे पता नहीं है. ये कहाँ की बात कर रहे हैं? How do you describe respiratory system examination? If you want to localize your findings in the respiratory system, how do you describe it? Middle part of the lung, what is that middle part of the lung? You mean in the center of the lung? Where do you mean?
In the back side of the, on the back side in the below the scapula.
Back side below the scapula. उसको डॉक्टरी लैंग्वेज में क्या बोलते हैं?
Inferior. Suprascapular, middle, and interscapular. There are three regions: suprascapular, interscapular.
आप बता रहे हैं, मैं उसका पूछ रहा हूँ. आपने कहा on the back side below the scapula. What is that called?
Infrascapular.
Infrascapular. Okay. So on in the infracapsular region, on which side? Left side, right side, both sides.
Both sides.
So infrascapular region bilaterally, you should be very careful because that is right over the trachea and major bronchi. Okay. So I am not sure whether you're truly hearing bronchial breath sounds or they were just transmitted sounds from the trachea, etc. But there could be bronchial breath sounds because this is important finding. What do you mean if he has bronchial breath sounds in that region? What are the causes of bronchial breath sound?
So some any cavitatory lesion could be there.
Yeah.
Or any
in addition, in a cavitatory lesion, in addition to bronchial breath sound, what else do you hear? You'll typically also hear crepitations, right? Because if there is a cavity in which air is going, right, it must be communicating with the major bronchus. And so if it is, then it will generally have some fluid inside it also. And so you will hear crepitations. Okay. So I find it really difficult to think of bronchial breath sounds in isolation. What is the other cause of bronchial breathing?
Any the consolidation in the lung fields.
All right, so consolidation could be, but this patient is afebrile, you are saying. He is lying
Yes.
comfortably, he is not tachypneic. You think it could be consolidation?
Very unlikely.
Likely. So I really don't know what to make of your respiratory findings. Okay, so let's just leave it at that. All right, go on, describe the rest of it.
In the cardiovascular system, there on the inspection, the precordium showing
Any positive finding? Any positive finding in cardiovascular system?
no, sir.
No. Okay. Abdominal examination?
In the abdominal examination,
any positive finding?
No positive findings.
No positive finding. Other systems?
In the central nervous system,
any positive finding?
No, sir.
Okay. Then, did you examine the fundus?
Yes, sir. So fundus was having the no dilated vessels. There is normal looking vessels and no abnormality was detected. The fundus was looking appearing normal.
All right. I see that many of you again have your videos switched off. Puneet, I'm going to ask you to kick out people who have not switched on their videos. Okay, so you can just kick them out.
Okay, sir.
If they don't do it in next 2 minutes, kick them out. So I'll read out their names: Saurabh Shukla, Gaurav, Radhika, Mohit, Sandeep. You can kick them out. Bhayo, Leena. ठीक है, अगर अगले 30 सेकंड में ये लोग नई वीडियो ऑन करते हैं तो इनको निकाल दीजिए.
Okay, sir.
Okay, so right. So what do you now summarize your examination findings and your history and examination, and then tell me what is your differential diagnosis.
The urine routine examination, I also.
चलिए बताइए.
So in the urine routine examination, it's pale yellow in color and clear in appearance. the pH of 5 with a specific gravity of 1.010 or 1.015, and protein were 2 plus, and RBCs, red blood cells of 150 per hypophil, and having no cast, and the glucose were absent, and WBCs of 2.
What is 2?
WBC, 2 WBCs were there.
Okay. All right. So now tell me, what do you make of your entire story?
So
what is the extra information that you got from the physical examination?
some in the chest system examination, there is bronchial breath sounds, as well as in the urine routine examination, proteinuria, as well as the hematuria was there.
Hematuria, you said 1 to 3.
Microhematuria. It's RBCs of 150 RBCs were there.
150.
150. 150.
150.
Yes.
Okay. You counted them? How did you know 150? Or how does that number, one get that number?
Yes, sir.
How did you get 150? Did you count 150? How do you get 150? I don't understand. Did you do the urine examination?
Yes, sir, I did.
तो कहाँ से 150 के आपने माइक्रोस्कोप के अंदर 1 2 3 4 काउंट किया? How do you do urine microscopy? How do you do red cell estimation or white cell estimation? When you say?
So for that, the urine sample, after spinning, taking the samples and spinning at 3000 to 3000 RPF for about 5 minutes, the supernatant were discarded, and then from the remaining part, I took on the slide, and after applying the slide cover, I visualized in the microscope with 50x and then 100x.
50x. 50x and 100x. Is that what you're saying?
Yes, sir.
How do you get 50x? Is there a lens that comes with 50x magnification?
So, sorry, 40. So 10. So 40x.
सच बता दो, तुमने किया था urine examination? Did you spin the urine? Did you look at the urine under the microscope? एकदम सीने पे हाथ रख के बताओ. Then we'll move on. Otherwise, I'll keep torturing you.
No, sir, I didn't.
Okay, all right. So from next time, at least read how to do it. अगर नहीं भी किया ना तो कम से कम बेईमानी में भी थोड़ी सी होशियारी करनी चाहिए, right? पढ़ के तो आओ कि कैसे करते हैं, माइक्रोस्कोप में क्या होता है. So at least according to the report that you got, there were lots of RBCs in the urine. Okay, is that what you're saying?
Yes, sir.
So if you get so many RBCs, what is the next thing that you should see?
Any RBC cast?
Okay, were there any RBC casts?
No, sir.
Let's say if you've done a urine examination, you see there are lots of RBCs. Now I ask you, can you please do the examination again, this time specifically focusing on the casts? So what is it that you need to do? How do you make sure that you will not miss any casts? Anyone else has any thoughts to offer? Someone says, look at the edges of cover slip. Sapna, yeah, that's right. But before that, let's say if I am a patient, I come to you, you ask me, give a urine sample. I give you a urine sample at 8 o'clock in the morning, and then you look at it at 4 in the afternoon. What will happen? So one is that you should process the urine sample as soon as possible. It should be a fresh urine sample preferably. Secondly, you should look at the urine pH. Cast dissolve in alkaline pH. So the urine pH should be acidic. If the urine pH is not acidic, add a drop of acetic acid to the urine so that your casts will remain stable. And then you spin the urine at a relatively low speed, right? So spin at 1000 RPM, okay? Not 3000 that you would normally do, okay? Spin for a little longer, spin at 1000 for 10 minutes, not too long, and then look at the edges of the cover slip. So those are the methods of making sure that you don't miss any casts. What else? Let's say you didn't see any casts. What else? Is there any other thing that you want to see still in the urine? Someone says phase contrast microscopy. Why are you doing phase contrast microscopy?
For to look for any the crenated RBCs, dysmorphic RBCs.
Crenated, क्या बोलते हैं उसको? Crenated dysmorphic क्या बोलते हैं? Crenated RBCs कहाँ पे होते हैं?
It is of the glomerular origin.
Okay. All right. So basically, you want to look for dysmorphic red cells in the urine. Okay, that's fine. Did you look for them? What do they look like?
Irregular in shape, distorted. The border lines are distorted.
Irregular, ठीक है, that's easy enough to say, but they are typically, they have blebs and they're hypochromic. Okay, so these are the two features that you identify them with. They will have typically, so they are called what type of cells? Someone has written acanthus.
Mickey Mouse.
So that is what they look like. So you look for them, and if they're there, then you have your diagnosis of glomerular disease, okay, glomerular nephritis. So in this patient, did you have those?
No, sir.
You didn't have those. So then what is your, now what is your diagnosis?
It's a possibility of definitely it's a case of
Which is the condition that you have excluded from your earlier differential diagnosis? सपना जी जल्दी जल्दी किताब से देखेंगे, कोई बात नहीं. Have you excluded any condition based on your findings or physical examination?
As there is RBCs are present, so definitely the renal dysfunction is of the glomerular nephritis is renal component is there. Proteinuria.
If RBCs are there, it's only glomerular nephritis?
No, proteinuria as well as the RBCs both are here. So possibility of.
You said 3 plus proteinuria, right? So I agree with you, there is some proteinuria, but then it is neither here nor there. Qualitative urine examination doesn't tell you very much. This person doesn't have any edema. This person doesn't have any hypertension. Right? So hematuria, can hematuria be present in acute interstitial nephritis?
Yes, definitely.
What percentage of patients will have hematuria?
30% microhematuria.
30% macrohematuria or microhematuria?
Micro.
30% microhematuria, is that right? Anyone else has any other opinion to offer? Microhematuria? Actually, 1/3 can have even macroscopic hematuria. Microscopic hematuria is much more frequent in acute interstitial nephritis. So I wouldn't rule out acute interstitial nephritis on the basis of the findings you have. I agree with you that the presence of proteinuria argues more in favor of glomerular disease, but it doesn't exclude the presence of acute interstitial nephritis. That's important for you to remember. Right? So how will you investigate this patient?
First of all, the routine blood investigations, that is complete hemogram. So that is showing the hemoglobin of 8.5, WBC counts of 14,700, and the platelet count of 2.1 lakh. And in the renal parameters, it's a urea of 238, and the creatinine is now 8.9, and the electrolytes are normal. In the liver function, it's a normal liver enzymes with.
Why are you telling me liver function test?
Also, I would like.
I'm asking you, what will you do? I'm not asking you to read the reports. How will you investigate this patient?
So first of all, I would like to know about the complete hemogram as well as the kidney functions, and viral markers as well as the
Why do you want to know viral markers before anything else?
because to rule out any hepatitis C and B especially can present with hepatitis C, especially cryoglobulinemia can be there.
Is that so? You will do that before even you know whether the patient has cryoglobulinemia or not? That is relevant only if that the person has cryoglobulinemia, right?
So
You should prioritize your investigation. What is the purpose of investigating a patient? The purpose is one, to get a diagnosis. Second, decide what treatment you want to give. And third, to prognosticate the patient. And fourth, looking at the possibility of any unintended consequences like risks, etc. Right? So for making a diagnosis, you said correctly, you want to look at the hemogram, you want to look at his kidney function, you want to look at his urine examination, which you have done. Okay, and you have now certain findings. So next, what will you prioritize?
Next, I would like also do the CT examination of the chest as well as the 2D echo of the
Chest
heart.
X-ray नहीं करते हैं क्या? CT examination सीधा?
Chest X-ray already done today.
Already done. I asked you, what will you do?
Yes, sir.
Which hospital are you from, my friend? Where are you doing your DNB?
Sir, Medanta.
Medanta में डॉक्टर खेर ने यही पढ़ाया आपको? I am going to talk to him. The standard in Medanta has deteriorated quite substantially, it seems. What does the chest X-ray show?
So the chest X-ray showing the peripheral the opacities was there,
Huh?
and the
Peripheral opacity. वो क्या होता है?
chest X-ray was in the bilateral lung field, minimal CP angle blunting was there.
Minimal CP angle blunting. You said he had bronchial breath sounds bilaterally. So there was nothing in the lung parenchyma?
No, sir. Peripheral opacity, some opacities was there in the basal area only.
I really doubt what are you saying. Okay. Anyway, I mean, there's no point in discussing this. You will do chest CT. What do you want to look for in chest CT?
I would like to exclude any chest infection, active chest infection, as well as any active hemorrhage is there.
Chest X-ray is normal. As you are saying, you are not seeing anything in the lung parenchyma. You are only seeing mild CP angle blunting, which is not a feature of parenchymal opacity. Parenchymal problem. It simply indicates some degree of pleural effusion. So either you are not describing the chest X-ray appropriately, or the chest doesn't have anything. You can do chest CT, but I don't expect you to find anything if the chest X-ray is as you are describing. But in terms of just working up the patient, what else will you do? Because you are suspecting either RPRF of some sort, RPGN or AIM. Will you do some other type of examination?
Pardon, sir?
Anything else in the urine will you look for now?
Total.
For AIN, what special test do you do in the urine? Acute interstitial.
Urine eosinophils.
How do you look for eosinophils in the urine? No? Anyone knows how to look for eosinophils in the urine? No one knows how to look for Hansel stain, someone says. Shikha Sharma says. Yeah, Hansel, any other stain, you know? Right stain. Okay, so these are the two stains that you use to look for urine eosinophils. All right.
Also the total urine 24 urine protein creatinine ratio. I would also
urine protein creatinine. If जिसने भी urine protein creatinine ratio बोला है ना, वो fail हो जाएगा. Because urine protein creatinine ratio should never be your first estimation of proteinuria. It should always be done in a 24-hour urine sample. Okay. You can use urine creatinine protein ratio to follow up a patient. But the first assessment, always, just remember, always should be in a 24-hour urine sample. Okay. And in a person who has a serum creatinine of 8, 24-hour urine protein doesn't have much meaning anyway. Why? Because urine protein excretion depends upon the glomerular filtration rate. And here the glomerular filtration rate is so low that even if there is a gross breach in filtration barrier, the proteinuria may not be very high. That is why I said in a person with creatinine of 8.6, 1 plus, 2 plus, 3 plus protein doesn't really mean very much. So, but you should still do the 24-hour urine protein. That's important. Then again, Shikha writes chest X-ray, ANCA, anti-GBM, 24-hour urine protein. So that's right. You will obviously do all these serologies. You will do ANCA, you will do anti-GBM, you will do complement levels. These are the investigations that you must do. Right. So that's important. So any of these investigations done? I know that we are almost out of time.
Sir, so ultrasound abdomen was showing the normal size kidney as well as the immunological workup. The complement level was normal, and the ANA was ANA by AFA was negative, and the ENA profile was negative. In the ANCA test by the ELISA, it's showing the
ANA profile. अगर आपने किया तो वो गलत किया. Again, if Medanta faculty member ordered ANA profile, it was a waste of money. You should do ANCA, right? You don't do an ANA in this patient.
So ANCA by ELISA showed the MPO of 66, and that is having the standard value less than 5. So it was strongly positive, as well as the PR3 was negative and anti-GBM were negative.
All right. So you have a strongly positive ANCA. Okay? So this is how you should prioritize your investigation. If you did ANA in this patient, you made him or her waste his money, right? So I would have right away done ANCA because that is the most likely investigation which will be positive, because this patient had some systemic symptoms. This patient had microscopic hematuria. And if I am looking for one vasculitis, I'm looking for small vessel vasculitis. That is the most likely one. So then what will you do next?
So as the ultrasound is showing the normal size kidney, so definitely I would like to go with kidney biopsy.
Okay, so was that done in this patient?
Yes, sir. That was showing the gross. It was in the light microscopy single core of 10 mm. In the IF, it was core of 5 mm. And then the glomerular compartment, the 10 glomerular was there, out of which 9 were cellular crescents, and the predominantly of the same age. The 3 segmental and 3 global circumferential, and the 2 was showing the necrotizing lesions with fibrin deposits with no endocapillary proliferation. In the tubulointerstitial compartment, there is diffuse acute tubular injury with patchy interstitial edema and 10 to 15% of IFTA with moderate patchy interstitial inflammation.
So what does this mean? So this is the light microscopy that has been given to you. All right, you don't know anything about this patient's history. I want you to predict what will be this patient's immunofluorescence. What is your prediction? And I'll ask you the reason also. So don't just say something.
As the crescents of all of the same age, so it could be the anti-GBM possibility could be there.
But you're saying some crescents are segmental. Do you see segmental crescents in anti-GBM disease?
No, sir.
So how do you know they are the same age? What do you mean they are the same age?
That the inflammatory the component is started at the simultaneously involvement in the all glomeruli.
Plus, you said a number of other things also. You said there was a necrotizing lesion in the glomerulus, yes, right? Does that happen in anti-GBM disease?
No.
No. You said there was interstitial inflammation, right?
Yes, sir.
Does that happen in anti-GBM disease?
No, sir.
No. As I said before, anti-GBM is a non-inflammatory glomerulonephritis. So if you see inflammatory lesions, it is not likely to be anti-GBM disease, right? So it is likely to be either immune complex disease or quasi-immune disease. So between the two, which one is more likely?
Possibility of quasi-immune.
Why is it more likely? I'm talking only about the light microscopy. Why is it more likely to be quasi-immune?
No, sir.
No, it is, you are right. Your answer is right that it is more likely to be post-immune, but I'm asking you why. Because this patient had necrotizing lesions in the glomerulus. That is typically a feature of small vessel vasculitis. Okay? So that makes post-immune more likely, right? And you didn't say that there was any exudative proliferative lesion in the glomerulus. So if there is endocapillary proliferation, that is more in favor of immune complex glomerulonephritis. If there is no endocapillary proliferation, it again goes against immune complex. So between the two, I would predict that it is likely to be post-immune again. Okay, so that's the way you predict what is likely to be the immunofluorescence. So what was the actual immunofluorescence finding in this?
So it was the immunofluorescence was negative.
Okay, so it was post-immune, so which makes a diagnosis of which is consistent with the ANCA disease that you described. Okay, so that's good. All right, so we are out of time. So very quickly, just in the next 2 minutes, how will you treat this patient?
So as this is having the life-threatening organ involvement is there, so definitely I would like to go with in the induction phase. I would like to do the IV steroid pulse therapy for the 3 days, 500 milligram per kg, 500 milligram per day, and with then with IV cyclophosphamide.
So you will treat him with a combination of steroids and cyclophosphamide. This is a short duration illness. This patient came with very advanced kidney failure, etc. So you will treat him with this. Will you do plasmapheresis?
The plasmapheresis is not showing very much evidence.
Yes or no? Yes or no?
No, no, sir.
You will not do plasmapheresis. Anyone wants to do plasmapheresis? Because I can see Mohit nodding his head. Why do you want to do plasmapheresis?
Sir, because the patient is also having lung hemorrhage.
But lung hemorrhage कुछ बताया नहीं. He says the chest X-ray is completely normal.
Yes, sir.
Right? So someone says it can be double positive. Of course, so immunofluorescence you will do, but this patient immunofluorescence was negative. You don't make a diagnosis of double positive on clinical grounds. That's just immunofluorescence finding. If you find it, well and good. But if no, it's unlikely. Right? All right. Thank you, guys. I need to go on another call. So, so good to talk to you once again, and we'll meet soon. Okay.
Thank you, sir.
Bye.
Thank you so much, sir. Thank you.
Thank you, sir.